general practitioners are faced with surgical responsibilities in their routine practice. Even simple tooth extraction can become a surgical procedure. And more predictably, many patients need to have impacted teeth removed or require surgical endodontics. Much of this work can be accomplished under local anesthesia in the dental chair. The decision to attempt surgery or refer the patient to hospital depends upon the nature of the procedure to be done, the patient, the experience of the dental practitioner, and the surgical facilities available. It's all a question of access. Successful surgery starts as a question of access to the right patient and the right operation. In other words, case selection. The medically compromised patient may not stand out in a crowd or be conspicuous in the waiting room, but recognition of potential medical problems is crucial.
What we're going to do, as you know, is to remove this root for you, and I just want to ask you a few questions about your medical history.
So it's vital to establish the suitability of a patient for minor oral surgery in dental practice by delving into the patient's medical history.
Have you ever had any illness that's taken you to hospital in your life?
Obviously, patients with absolute contraindications should be referred for hospital management. But there are many people with well-controlled conditions who are on regular medication but present no specific contraindications to minor oral surgery under local anesthesia.
And we're going to remove that for you by working in this part of your mouth up here. Now,
some people will always remain emotionally unsuitable for surgery.
So that you won't feel anything at all.
To many others, the idea of any kind of surgery, even minor, without a general anesthetic is frightening. Even the word surgery can cause fear.
Afterwards, it's going to leave you with some soreness, some swelling, and some...
But a few minutes sympathetic explanation of the proposed treatment, with an emphasis on pain control, usually puts their minds at rest.
And so we intend to make you feel...
And there's always the fallback of sedation in combination with the local anesthetic. Careful selection of operation is the cornerstone of successful surgery. Procedures to be undertaken with local anesthetic should have an identifiable goal which is achievable within 30 minutes planned operating time. Routine surgical problems, such as the removal of buried roots or teeth fractured during extraction, uncomplicated third molars, and apicectomies on anterior teeth should fall comfortably within this limit. Surgery in areas of the mouth having potentially difficult access, teeth buried in the palate for example, should be avoided. So what are the key considerations in deciding operative difficulty, and the most important factors in deciding whether to undertake surgery or not? Obviously, good physical access makes operating easier. An estimation of the depth and orientation of the tooth will give a good indication of its accessibility. The amount of bone removal required depends upon the shape, size, and number of roots, as well as the size of the crown, which together determine the direction in which the tooth must move. The accessibility of effective application points should be estimated. The relationship to nearby structures must be considered. Nerves close to the operating site. Adjacent teeth which may inhibit bone removal. The proximity of root apices to the maxillary antrum. And the lack of space between the distal aspect of the lower second molar and the ascending ramus. Bone loss due to infection or cyst formation may simplify removal of the tooth. However, larger lesions, such as this dentigerous cyst, threaten jaw fracture. It goes without saying that patients' mouths offer varying degrees of physical access to the sites of operation.
The texture of bone varies greatly with age, physical build, and ethnic origin.
Good quality radiographs which show the whole of the surgical field are crucial in the assessment for surgery and for a medico-legal record. Bad quality radiographs turn the assessment into a lottery.
If patients are properly briefed beforehand, if they're given enough information so that they feel happy and give informed consent for surgery, then in my experience, they're uniformly grateful for treatment from someone they know, rather than facing the unfamiliarity of the hospital and the possibility of long waiting lists. When managed properly, mind oral surgery can actually be a practice builder.
The dental surgery only requires a few additional items to complete the surgical kit. Items such as instruments to cut, raise and reposition flaps, retractors for the tongue, cheek and buccal flaps, and a prop to maintain comfortable access. A straight handpiece with a selection of sterile burrs, universal forceps and some basic elevators. Some suture material, such as 3/0 braided silk, a small supply of resorbable hemostatic gauze and bone wax for the rare occasions when hemorrhage becomes a problem. And for apicectomies, a Mitchell's trimmer and some excavators, as well as amalgam instruments for retrograde root filling. When used for surgery, the local anesthetic has several functions. Naturally, it controls pain during the operation, but it also produces welcome post-operative analgesia. In addition, the vasoconstrictor component of the anesthetic assists greatly in the control of hemorrhage. Therefore, the placement of generous quantities of local anesthetic, both for regional blocks and local infiltration, is highly desirable. It's particularly important to allow sufficient time to elapse following infiltration of the local anesthetic into the tissues which will become the flap. Otherwise, the depot of anesthetic is too quickly removed, causing inadequate anesthesia. Occasionally, difficulty is experienced gaining adequate anesthesia into the deep recesses of a periapical lesion. This can usually be rectified by injecting the anesthetic into the soft tissue granuloma before curettage begins. The principal objective of flap design is to ensure adequate access to all areas of bone which may need to be removed. This leaves the incision line well clear of the proposed defect. In the case of the lower wisdom tooth, this means taking the distal limb of the incision distobuccally across the retromolar region to the base of the ascending ramus. Palpating the anterior border of the ramus helps to ensure that the scalpel doesn't stray lingually, where it may damage the lingual nerve. The mesial limb starts at the distobuccal corner of the second molar with the blade in the gingival crevice, and continues across the oblique ridge, keeping parallel with the root of the second molar. Once at the mucogingival junction, the incision is curved forwards for about 1 centimeter. If the mesial relieving incision is not brought sufficiently forward, then access to the mesial point of application on the third molar will be blocked. If the incision is carried too far into the depth of the sulcus, no additional access is made, but the likelihood of excessive hemorrhage is increased. The leaving incisions are designed to include a whole interdental papilla, which is then available for accurate replacement of the flap by suturing it to the lingual or palatal gingival tissue. It's important to cut through all layers from the mucosa to the periosteum in one clean movement to ensure a neat edge to the flap and to facilitate subsequent reflection of the periosteum. Alternatively, apicectomy flaps can be made which do not involve the gingival margin, either by forming the semi-lunar pattern or a square-sided flap. These flaps are simpler to replace, but can restrict access to areas of the root. The best place to begin raising this mucoperiosteal flap is in the lax tissues of the vestibular mucosa. This allows instant access into the correct plane of dissection at the subperiosteal level. Once the bony surface is identified, the periosteum under the attached gingiva can be lifted to free the papilla and the gingival margin. Once the flap has been raised, visual access to the operating site, as well as access for instrumentation, is maintained by accurate retraction. In addition to retracting the flap, this instrument also neatly holds the cheek out of the way. Any soft tissue lying over the crown of the tooth or on its distal aspect should be freed at this stage using a Haworth's periosteal elevator. If distal bone removal is required, this instrument should be placed over the lingual margin of the mandible distal to the third molar, taking the utmost care to position it in the subperiosteal plane, so as to retract the lingual soft tissues, including the lingual nerve. Remember, though, this retraction is not infallible protection for the lingual nerve. Removing bone should achieve specific objectives. These objectives are to clear the path of exit of the tooth by removing those areas of bone obstructing elevation, and to gain access to effective points of application which will enable elevation of the tooth. Most superficial third molar impactions can be relieved by the combination of distal and buccal bone removal, with points of application from the mesial and buccal aspects of the tooth. When using a burr distal to the third molar, it is essential not to inadvertently perforate the lingual plate, thereby risking damage to the lingual nerve, and the direction of cutting should be towards the buccal side, always moving away from danger. Bone removal for buried roots should clear the buccal surface sufficiently to permit an elevator to be used on both the mesial and distal aspects of the root. A more secure point of application can often be achieved by using the furcation of a multi-rooted tooth or cutting a small notch in the surface of the root dentine. Burrs used for cutting bone need to be cooled with a suitable irrigant, which also helps to clear the operative site of debris. In this case, the wisdom tooth is being elevated by tipping the crown of the tooth backwards from a mesial point of application. Upward movement and subsequent delivery of the tooth is by displacement from the buccal side. The elevated tooth can then be safely lifted out of the mouth with extraction forceps.